Good morning, doctors. Today we are on a 21st day of studying Oxford Handbook of General Practice. I am your study buddy, Dr. Sesha, and we are studying together for MRCGP International AKT exam. We are at page number 445, chapter Musculoskeletal Problems, chapter 14. Let's start studying. 446. Symptoms of musculoskeletal disease. Bone pain. If there is a bone pain, consider fracture due to injury, stress fracture, or pathological fracture, arthritis, referred pain from affected joints, malignancy, primary bone malignancy, hematological malignancy, example a multiple myeloma, or secondaries, usually from the breast, the prostate, the lung, the thyroid, the kidney, more rarely the bowel, melanoma. Benign bone tumor, infection, osteomyelitis or joint infection, metabolic causes, example hypercalcemia, pain in one joint. Common. Ask, is the problem articular or periarticular? Articular disease, example osteoarthritis, is suggested by the joint line tenderness and pain at the end of the range of movement in any direction. So this is pain at the end of the movement in any direction is an articular disease. Periarticular problems, ligamentous injury, point tenderness over the involved structure and pain exacerbated by movements. If articular, is the problem inflammatory or mechanical? Look for signs of inflammation, warmth, redness, effusions may indicate joint infection or inflammatory arthritis. Features of mechanical problem, look for locking or catching, example a cartilage tear. If periarticular, which structure is causing pain? Options are bursa, tendon sheath, ligament, soft tissue, bony epiphysis, or metaphysis. Red flag signs in bone musculoskeletal disorders. Features which should prompt early or urgent referral. An inflamed joint with associated fever or constitutional disturbance. Beware of septic arthritis. Any joint which is locked or so painful that movement is impossible. Severe pain at rest or at night. Pain that gets relentlessly worse over a period of days or weeks. Pain in multiple joints. Differentiate between the articular or periarticular disease and whether the condition is inflammatory or not. Screening with blood tests like ESR, CRP, FBC, plus or minus autoimmune profile may help. Look for the pattern of disease, the joints involved, joint sites involved, other symptoms and signs. Common arthropathies. They are detailed in page 486. Osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, SLE, reactive arthritis, psoriatic arthritis, enteropathic arthropathy, gout or pseudogout, Sjogren's syndrome and malignancy. Red flag signs, features should prompt early urgent referral in arthropathies. Severe systemic symptoms with high fever, significant weight loss or a very ill patient suggest rheumatoid arthritis, sepsis or malignancy. Focal systemic signs like rashes, nodules or GI disturbances, severe pain or inability to function. Back pain, neck pain, joint stiffness. Clarify what the patient means by stiffness. Stiffness may be referred to either a loss of range of movement plus pain or pain on movement. Example, following unaccustomed exercise. Morning stiffness is a pain that eases on movement and is characterized by characteristic of inflammatory arthritis, particularly rheumatoid arthritis. Joint swelling. Common. Ask, what does the swelling feel like? Is it a hard or bony swelling or deformity, usually osteoarthritis, example the osteophytes, but may also result from destructive arthropathy, example the inflammatory arthritis, Charcot's joint injury or heterotopic calcification. Usually if it's a hard swelling, then it could be either osteoarthritis or destructive arthropathy or injury or heterotopic calcification in a joint. Soft and fluctuant. The swelling in a joint is soft and fluctuant, suggests joint effusion as a result of inflammation or infection within the joint. Soft and non-fluctuant, soft tissue swelling resulting from injury or infection or inflammation. Firm and non-fluctuant, synovial thickening resulting from inflammatory arthritis. Deformity. Abnormal shape may be temporarily, example, soft tissue swelling after an injury, new fracture, or permanent. Congenital malformations like Paget's disease, osteoarthritis. Look for underlying cause. So deformity, the joint deformity can be temporarily due to a soft tissue swelling, injury, or new fracture, or a permanent deformity because of congenital malformation, Paget's disease, osteoarthritis. Look for the underlying cause. Dystonia, chest deformity, short stature, excess height. Myalgia. Isolated myalgia can be a result of overuse or soft tissue injury. Generalized myalgia is associated with many diseases like infection, fibromyalgia, chronic fatigue syndrome, myositis associated with strain, and granulomatosis with polyangiitis. Children with musculoskeletal pain of unknown cause. Take a history and examine carefully to exclude other causes. Investigate further with FBC, blood film, ESR, plus or minus X-ray if bone pain, rest pain, or persistent unexplained back pain. If no cause is found, treatment is with analgesia and reassurance. Advised to return for reassessment or orthopedic referral if pain worsens. Continue more than 6 weeks. Changes in nature or other symptoms develop. So you need to advise for reassessment plus orthopedic referral if the pain worsens, continues for more than 6 weeks, or changes in nature or other symptoms develop. Nocturnal musculoskeletal pains or growing pains. Episodic muscular pains usually in the legs lasting more than 30 minutes, waking the child from the sleep. Rubbing the limb brings rapid relief. There is no pain or disability in the morning. Diagnosis can be made on history if there is no associated symptoms and examination is normal. If in doubt, check FBC and ESR levels, which should be normal. In most cases, reassurance plus analgesia are all that is needed. In resistant cases, physiotherapy may help. The limping child, we'll see at page 465. Neck pain. Neck trauma. Any significant cervical trauma requires neck immobilization with a hard collar and referral to a accident and emergency for cervical spine X-rays to exclude vertebral fracture, instability that could threaten the spinal cord. Neck pain is common. A lifetime incidence is 50%, contributes to 2% of GP consultations. Prevalence is highest in the middle age. Most neck pain is acute and self-limiting within days, but 1 in 3 have symptoms lasting more than 6 months or recurring pain. History. Pain. Onset site Socrates. Site onset radiation, aggravating relieving factors, timing. Stiffness, timing, continuous, worse in the mornings. Deformity, torticollis, onset changes. Neurological symptoms, numbness, paresthesia, weakness. Other symptoms, weight loss, sweats, bowel or bladder dysfunction. Consider spinal cord compression. Pain is often poorly localized and neck problems commonly present with shoulder pain or headache, cervicogenic headache. Examination. Look at the posture, the deformity, example torticollis, asymmetry of the scapulae, arms and hands, wasting, fasciculations, leg weakness. Feel the tenderness. Midline tenderness may be due to supraspinous or spinous process damage following a whiplash injury. Paraspinal tenderness plus spasm radiating to the trapezius plus crepitation is common with cervical spondylitis. Move and measure. Normal ranges. Flexion extension 130 degrees total range. Lateral flexion 45 degrees in each direction from the neutral position. Rotation 80 degrees in each direction from a neutral position. Neurology. That is the movement expected at your cervical spine. Neurology. Weakness in the upper limbs in a segmental distribution with loss of demonstrable sensation and altered reflexes indicates a root lesion. If cervical cord compression is suspected, examine the lower limbs looking for upgoing plantars or hyperreflexia. Why? If some lesion is there in the cervical cord, then it will be an upper motor lesion for the lower limb. So you have to look for upper motor neuron lesion signs in the lower limb like upgoing plantars or hyperreflexia. Cervical spondylitis. Spondylosis. Degenerative disease of the cervical spine may cause pain, but minor changes are normal, especially more than 40, and usually asymptomatic. Pain is generally intermittent and related to activity. Examination reveals reduced neck mobility. Severe degeneration can cause nerve root signs. Treat with analgesia. X-ray only if conservative measures fail. Troublesome pain, nerve root signs, or psoriasis. Psoriatic arthropathy is present. Nerve root irritation or entrapment. Secondary to degeneration, the vertebral displacement or collapse or disc prolapse, local tumor or abscess causes neck stiffness. Nerve root irritation or entrapment causes neck stiffness, pain in the arms or fingers, decreased reflexes, sensory loss, decreased power. Sperling's test. Neck extension plus rotation to the affected site followed by downward axial pressure reproduces the symptoms of nerve root irritation. This is called the Sperling's test. Determine the level of entrapment clinically. Treat with analgesia. X-ray cervical spine lateral or lateral views. Refer for physiotherapy plus further investigations, example an MRI, if conservative management fails and there is objective evidence of a root lesion. Neurology associated with cervical nerve root entrapment. So the nerve root and what would be the weakness? So C5. If there is a C5 entrapment, then sensory changes on the lateral aspect of the arm, motor weakness for shoulder abduction, flexion, elbow flexion, because it affects the biceps. Reflex is the biceps reflex. Reflex changes, the biceps reflex is affected. So C6, lateral forearm, sensory supply to the lateral forearm, the thumb, the index finger. Causes motor weakness with elbow flexion and wrist extension. Biceps and supinator reflexes. C7 is the middle finger is the sensory supply, affects the elbow extension. C7 for triceps, elbow extension, flexion at the wrist, finger extension. Triceps is the reflex that is affected. C8, medial side of the lower forearm, ring and little fingers, finger flexion. So all the flexion of all the fingers, because the small intrinsic muscles of the hand are affected. Tricep, no reflex is affected. T1, medial side of the upper forearm, finger abduction and adduction. So finger abduction and adduction is affected. T1 is compressed or entrapped, no reflex changes. So this has been asked many times, so you need to read it again and again to remember this. Let's go ahead. Red flag signs in nerve entrapment. Refer as an emergency if spines or spinal cord compression is present, but not nerve root. Root pain and lower motor neuron signs at the level of the lesion. And spastic weakness, brisk reflexes, upgoing plantars, loss of coordination and sensation below the lesion. Then you have to refer as an emergency because it is due to spinal cord compression. Spasmodic torticollis or wry neck. Common sudden onset painful stiff neck due to spasm of the trapezius and sternocleidomastoid muscles. Self-limiting. Heat, gentle mobilization, muscle relaxants and analgesia can speed up the recovery. So, spasmodic torticollis is spasm of the trapezius and sternocleidomastoid muscles. So, what you will do, you will give heat, gentle mobilization, muscle relaxants, analgesia, often caused by poor posturing. Example, computer seating position, carrying heavy or uneven loads. Thoracic outlet syndrome is caused by neurovascular compression as the nerves or blood vessels pass through the thoracic outlet ring formed by the scalene muscles, the first rib and the clavicle. May present with the shoulder or arm pain, weakness or paresthesias plus thenar and hypothenar wasting. Radial pulse may be weak. Refer to upper limb orthopedic surgeon for assessment if suspected. Congenital C7 costal process enlargement. Cervical rib, congenital C7 costal process enlargement, usually asymptomatic but can cause thoracic outlet syndrome. X-ray may show a cervical rib, but symptoms are sometimes due to fibrous bands not seen on the X-ray. Whiplash injuries. Neck pain caused by stretching or tearing of the cervical muscles and the ligaments due to sudden extension of the neck, often due to RTA. Pain and decreased neck mobility typically start several hours or days after the injury. Pain may radiate to the shoulders, the arms, and in the head. Management of a whiplash injury. Examine to exclude any bony tenderness requiring an X-ray. Treat with analgesia and early mobilization. A soft collar may help initially but avoid long-term use. Recovery is often slow. 40% suffer long-lasting symptoms. As a general rule, the quicker symptoms develop and the longer they take to disappear. Early physiotherapy, if available, increases the recovery rate. Psychological problems and medico-legal issues may affect the progress. Low back pain. Definition. Acute low back pain. New episode of low back pain of less than 6 weeks duration. Common lifetime prevalence is 58%. Chronic low back pain. Back pain lasting more than 3 months. Causes of back pain. History. Ask about the circumstances of the pain. History of injury, duration, nature or severity of the pain. Pain stiffness mainly at rest or at night, easing with movements suggest inflammation. So inflammatory pain which is there, that actually eases with movements and increases with rest. Discitis, spondyloarthropathy. Associated symptoms, there is numbness, weakness, bowel or bladder symptoms. PMH, past illness, example, cancer, previous back problems. Exclude pain not coming from the back. GI or GU pain or abdominal aortic aneurysm. Examination. Deformity. Check for any deformity. Example, if there is a kyphosis typical of ankylosing spondylitis. Loss of lumbar lordosis common or in acute mechanical back pain. Scoliosis. Palpate for tenderness, step deformity and muscle spasm. Assess flexion, extension, lateral flexion, rotation while standing. Ask to lie down. This gives a good indication of severity of symptoms. In lower limbs, look for muscle wasting. Check for power, sensory loss and reflexes, the knee jerk or the ankle jerk reflex. Assess the straight leg raising test. Sciatica if present is present if SLR on one side elicits back or buttock pain. usually ipsilateral, compared to SLR on the other side. Red flags. If the patient is low back pain plus red flags, less than 20 years or more than 55 years, non-mechanical pain, pain that worsens when supine, nighttime pain, thoracic pain, past history of cancer, AAA, HIV, immune suppression, IV drug use, taking steroids, unwell, weight loss, widespread neurology, structural deformity. Management of acute back pain in the community. Try it according to the history and examination. For patients who do not require immediate referral, consider analgesia, example NSAIDs for short time, plus consider gastroprotection. Weak opioids, either you start NSAIDs and consider gastroprotection, give weak opioids plus paracetamol, use Neil Start Black screening tool for back pain in the community. Neil Start Back screening tool. So we'll see what it is in box 14.1. If the total score is less than 3, explain likely natural history of pain and advise to avoid bed rest and if the score, the Neil Start Back screening tool, if the score is less than 3, you need to explain likely natural history of the pain and advise to avoid bed rest and maintain normal activities as far as possible, and that will decrease the chance of chronic pain. Suggest self-help exercises. If the score is more than 4, check the questions 5 to 9 sub-score. If the score is less than 3, if it is not resolved within 4 weeks, refer for physical therapy. Options include back exercises, classes, physiotherapy, chiropractic, osteopathy or acupuncture if available. If more than 4 and if not resolved in 4 weeks, refer directly for specialist intervention sooner if worsening or severe pain. In all cases, challenge any yellow flag factors that may inhibit recovery and delay return to normal functioning. Figure 14.1. This is a table 14.2. Causes of back pain. Age suggests the most likely cause. So, in age 15 to 30 years, the causes could be postural, mechanical, prolapse disc, trauma, fracture, ankylosing spondylitis, spondylolisthesis, and pregnancy. 30 to 50 years. Postural, prolapse disc, spondyloarthropathies, discitis, degenerative joint diseases. More than 50. Postural, degenerative Paget's disease, malignancy, lung, breast, prostate, thyroid, kidney, myeloma. Osteoporotic collapse. So more than 50 you have to consider also malignancies and Paget's disease and degenerative disease and myeloma and osteoporotic disease after 50. Other causes could be spinal stenosis, cauda equina tumor, abdominal aortic aneurysm, spinal infection and referred pain. Table 14.3. Neurology with lumbosacral nerve root entrapment. So, like in the upper limb, we have seen C5, C6, C7, C8 and T1. So, here we are seeing L2, L3, L4, L5 and S1 entrapments and how they will present. L2 entrapment, the sensory changes will be in the front of the thigh. L2, front of the thigh, causes motor weakness in hip flexion and adduction. No reflex changes. L3, the inner aspect of the thigh, knee extension, helps with knee extension, and reflex changes is the knee jerk reflex. L4, the inner shin, knee extension, foot dorsiflexion. Again, reflex changes with the knee reflex, knee jerk reflex. L5, outer shin and dorsum of the foot, knee flexion, foot inversion, big toe dorsiflexion. Knee flexion, foot inversion, big toe dorsiflexion, no reflex affected. S1 nerve root compression, lateral side of the foot or sole, knee flexion, foot plantar flexion, ankle reflexes affected. So box number 14.1, this is kneel start back pain scoring tool. Ask the patient to consider the following statements and state whether they agree or disagree with them. Thinking about the past 2 weeks, my back pain has spread down my legs at some time in the last 2 weeks. Second, I've had pain in the shoulder or neck at some time in the last 2 weeks. I've only walked short distances because of my back pain. In the last 2 weeks, I have dressed more slowly than usual because of the back pain. It is not really safe for a person with a condition like mine to be physically active. Worrying thoughts have been going through my mind a lot during this time. I feel that my back pain is terrible and it's never going to get any better. In general, I have not had enjoyed all the things I used to enjoy. If the patient agrees with a statement, score 1. If he disagrees, score is 0. So, overall, how bothersome has your back pain been in the last 2 weeks? Not at all, slightly or moderately, score 0. Very much or extremely, score 1. And there was a classification less than 3 and 4 just here. If the total score is less than 3, explain the natural history of pain and advise for bed rest to avoid bed rest and maintain normal activities. Score is more than 4, check questions 5 to 9 and then sub-score. So if the score is more than 4, then you have to check 5 to 9 questions and then give a sub-score. And then if the sub-score is again more than 3 and the pain is more than 4 weeks, if the sub-score is total score is more than 4, check the 5 to 9 sub-score. If it is 5 to 9 score is less than 3, if it is not resolved in 4 weeks, refer for physical therapy. If the 5 to 9 sub-score is more than 4, if not resolved in 4 weeks, refer for specialist intervention. That is the kneel start back pain score tool. Musculoskeletal problems, page 452. There is this management of acute back pain. Let's see what is the heading. The triage of acute back pain. This is in the triage. So let's see. So acute back pain, possible fracture, a history of major trauma or minor trauma if known osteoporosis. If yes, if you are suspecting a fracture, then fracture confirmed, manage accordingly. So do a plain X-ray. If the fracture is confirmed, manage accordingly. If the plain X-ray fracture is not confirmed, follow up in 10 days. On review, if fracture is still suspected or multiple sites of pain, consider bone scan plus referral, and then fracture is confirmed, manage accordingly. So after, if possible fracture is no, possible cauda equina syndrome or rapidly progressive neurological deficit, because this is acute back pain, not acute onset. So it could be a possible cauda equina syndrome or a rapidly progressive neurological deficit. History: is there any saddle anesthesia or splinter dysfunction, bladder or bowel dysfunction? On examination, severe or progressive lower limb neurological deficit or major motor weakness, unexpected laxity of the anal splinter, or perianal or perineal sensory loss. If it is yes, then immediate admission. So cauda equina syndrome or rapidly progressive neurological deficit is yes, you immediately admit the patient. If that is no, possible serious pathology, any red flag signs are present or not, you have to see. If any red flag signs are present, then check the FBCs, ESR or CRP. These increase in the metastasis, myeloma, discitis and often ankylosing spondylitis. Check the calcium, phosphate and alkaline phosphate which increases in Paget's disease and tumors. Consider checking the PSA, arrange a lumbar spine and a pelvic X-ray. And refer for any abnormalities on testing if not resolving in less than 4 weeks. Nerve root pain. So there are no red flag signs, then you are thinking it is a nerve root pain. Pain radiates to the foot or toes. Unilateral leg pain is worse than the low back pain. So the pain is radiating to the foot or the toes. There is a unilateral leg pain which is worse than the low back pain. Numbness or paresthesia present in the same direction as the pain. SLR reproduces the leg pain. Localized neurological signs, example, there is an absent ankle reflex on the same side. Then, if it is yes, specialist referral is not needed in the first 4 weeks, assuming signs of resolution. And if it is no, simple mechanical backache, age 20 to 55, well, mechanical pain in the lumbosacral area, buttock or thighs, no symptoms or signs of inflammatory disease. Yes, specialist referral is not required. Yellow flags are psychosocial barriers to back pain recovery. Belief that pain and activity are harmful. Problems or dissatisfaction at work. Sick behaviors, extended rest, social withdrawal, emotional problems, low mood, depression, anxiety or stress, problems with claims or compensation or time off work, overprotective family, lack of support, inappropriate expectations of treatment. So these are the psychosocial barriers to back pain recovery. So do not X-ray routinely. X-rays require a high radiation dose and clinically meaningful findings are rare. Exceptions are in a young patient less than 25 years, X-ray sacroiliac joints to exclude ankylosing spondylitis. Elderly, if there is a vertebral collapse or malignancy suspected, history of trauma is present. Then only X-ray. Otherwise, routinely don't X-ray in a back pain. Cauda equina syndrome. Is compression of the cauda equina below the L2 level, by example by a disc protrusion at L4 L5 level, presents with numbness of the buttocks and back of the thighs, urinary and fecal incontinence, low motor neuron weakness at L4, loss of dorsiflexion of the foot and toes L4 L5, S1 loss of ankle reflex, plantar flexion and eversion of the foot. So whenever there is a L4, L5 disc compression, then there will be lower motor neuron weakness at L4, L5 and S1 levels. So loss of dorsiflexion of the foot and toes and loss of ankle reflex or plantar reflex or ankle reflex, plantar flexion and eversion of the foot. So if it is at S1, there will be loss of plantar flexion. Whereas if it is L4, there will be loss of dorsiflexion of the foot. Management, refer or admit as a neurological emergency. Rapid surgical intervention increases the chance of full motor and splinter recovery. Spinal cord compression affects 5% of the cancer patients, 70% in the thoracic region. Maintain a high level of suspicion if history of cancer and new back pain, especially if known bony metastasis or tumor likely to metastasize to the bone. Patients' presence with a back pain worse on movement often appears before neurology. Neurological symptoms and signs can be often presents before neurological signs. So back pain which is worse on movement, you should be very cautious. It could be spinal cord compression. Neurological symptoms or signs can be non-specific. Example, there could be constipation, there could be weak legs, urinary hesitancy, lesions above the L1, lower end of the spinal cord, produce upper motor neuron signs. Example, increased tone and reflexes and a sensory level. Lesions below the L1 produce lower motor neuron signs, that is decreased tone, reflexes and perianal numbness, cauda equina syndrome. Management, prompt treatment. Less than 24 to 48 hours from first neurological symptom is needed. Once paralyzed, less than 5% walk again. Treat with oral dexamethasone 16 milligrams per day. Oral dexamethasone 16 milligrams per day and refer for the same day assessment and surgery or radiotherapy unless final stages of the disease. Oral dexa and refer for same day assessment and surgery or radiotherapy unless final stages of the disease. Osteoporotic vertebral collapse, page 482 we will see. Scoliosis, lateral curvature of the spine associated with rotation of the vertebrae or ribs. plus ribs or wedging of the vertebrae. Early treatment prevents progression and complications. Example, cardiopulmonary disturbances. Causes are idiopathic infection like TB of the spine, congenital butterfly vertebra, metabolic, example, bone dysplasias, neuromuscular problems, example, cerebral palsy, neurofibromatosis, Friedreich's ataxia, muscular dystrophy, and polio. Trauma, damage in the vertebral growth plate and uneven growth, neoplasm, primary or secondary as a result of radiotherapy. Clinical features, difference in height, shoulder height, and spinal curvature, difference in the space between the trunk and the upper limbs. Scoliosis which disappears on bending is postural and of no clinical significance. Management. In all the cases where structural scoliosis is suspected, refer to orthopedics urgently if associated with pain, especially at night. Page 454, shoulder problems. History. Pain and stiffness. Joint pain is felt anteriorly and may radiate down the arm. Pain on the top of the shoulder suggests acromioclavicular joint problems or cervical spine disorders. Okay. Pain in the shoulder may be referred from the neck, the heart, the mediastinum, or the diaphragm. Deformity, swelling of the shoulder, prominence of the acromioclavicular joint or winging of the scapula. Loss of function, difficulty in reaching the back, doing up a bra strap or brushing the hair or dressing. Examination. Look at the posture, asymmetry, the muscle wasting, swelling. Large effusions can be seen anteriorly. Scars. Feel for tenderness, warmth, swelling, or crepitus. Feel for tenderness, warmth, swelling, or crepitus. Move. Compare the sides. Check the range of movement, complex movements, example the hands behind the head, arm across the front of the chest to top of the opposite shoulder and hand behind the back. Power. So you have to compare the movements of both the shoulders. So range of movement, complex movements like hands behind the head, arm across the front of the chest and top of the opposite shoulder, hand behind the back. So power. Also power you have to check. General rules. Intra-articular disease, painful limitation of movement in all the directions. Tendonitis, painful limitation of movement in one plane only. Tendon rupture or neurological lesions is a painless weakness. When there is a tendon rupture or neurological lesion, it is a painless weakness, whereas it's a painful limitation of movement in one plane, tendonitis. Intra-articular disease, painful limitation of movement in all directions. Red flag signs of shoulder. Past history of carcinoma, constitutional symptoms, example fever, chills or unexplained weight loss, recent bacterial infection, IV drug use, immune suppression, constant or worsening wrist pain, and structural deformity. Causes of a stiff, painful shoulder joint. Adhesive capsulitis, primary or secondary. This causes stiff and painful shoulder joint. Adhesive capsulitis, primary or secondary or to diabetes or intrathoracic pathology. Inflammation. Inflammatory arthritis like rheumatoid arthritis, psoriatic infection, osteoarthritis, prolonged immobilization, example in hemiplegia, strapping after a dislocation, polymyalgia rheumatica. These are the causes of a stiff and painful shoulder joint. Shoulder osteoarthritis often occurs after trauma, less common than the knee or hip osteoarthritis, may be associated with crystal-induced inflammation and secondary causes of osteoarthritis like gout, hemochromatosis. Imaging for synovitis, ultrasound or MRI is important to exclude the disease that may benefit from steroid injection. Consider referral for shoulder replacement if severe. Frozen shoulder or adhesive capsulitis. Overdiagnosed in primary care affects the patient's 40 to 60 years. Painful stiff shoulder with global limitation of movement, notably external rotation. Pain is often worse at night. Causes are unknown, but increase in people with diabetes and those with intrathoracic pathology, MI, lung disease or neck disease. Management. If not known to have a diabetes, check HbA1c. NSAIDs, physiotherapy and local steroid injection can all be helpful, may take more than 1 year to recover and long-term outcome is uncertain if restricted movements are present. Are slow to return, consider an orthopedic referral. Rotator cuff injury. The shoulder is the most mobile joint in the body and relies on the musculoskeletal, musculotendinous rotator cuff to maintain stability. So, disorders of the rotator cuff account for most of the shoulder pain. Acute tendinitis, often due to excessive use or trauma in patients less than 40 years, presents with severe pain in the upper arm. Patients hold the arm immobile and are unable to lie down on the affected side. Usually starts to resolve spontaneously after a few days. In the middle age can be caused by inflammation around the calcified deposits requiring steroid injections. Rotator cuff tears may accompany a subarachnoid impingement, difficult to diagnose clinically unless large suspect if recurrent impingement or positive drop arm test. So there's a positive drop arm test. So abduct the arm to 90 degrees. Ask the patient to lower slowly to decide if unable or pain on lowering. Test is positive. Refer. Subacromial impingement. Pain occurs in limited arc of abduction 60 to 120 degrees, painful arc syndrome or subacromial impingement or on internal rotation. If less than 40 years associated with glenohumeral instability from connective tissue laxity or labral injury, if older due to chronic rotator cuff tendinitis or functional cuff weakness or tear. Investigations. X-ray may show calcification of the supraspinatus tendon in acute tendinitis and irregularities or cysts at the humeral greater tuberosity if chronic cuff tendinitis. So even X-ray may show some calcification in tendinitis or irregularities or cysts in humeral greater tuberosity if the chronic tendinitis is there. Dynamic ultrasound may demonstrate impingement, tendonitis or rotator cuff tears. Treatment. Rest and NSAIDs followed by physiotherapy and or subacromial steroid injection. If conservative measures fail, refer for a specialist management. Shoulder dislocation. Usually due to fall on the arm or shoulder, anterior dislocation is most common. Shoulder contour is lost, flattening of the deltoid and the head of the humerus is seen as an anterior bulge. Axillary nerve may be damaged. Absent sensation on a patch below the shoulder. Refer to emergency department for X-ray and reduction. In young patients less than 30% go on to have recurrent dislocations due to labral tear. Dislocation is associated with rotator cuff tear in 25% of the elderly people. Recurrent dislocation. Usually anterior and follows a trauma. 5% are teenagers with no trauma but general joint laxity. Refer for specialist physiotherapy and consideration for surgery. Rupture of the long head of the biceps. Discomfort in the arm on lifting and feeling of something going. A lump appears in the body of the biceps muscle on elbow flexion. May be associated with other shoulder pathology. Management. Exclude a distal rupture of the tendon at the elbow. Reassure no treatment is necessary. Acromioclavicular joint problems. Pain on the top of the shoulder or in the suprascapular area suggests a problem with the AC joint or the neck. Pain at the top of the shoulder or the suprascapular area suggests a problem with the acromioclavicular joint. AC joint pain is usually due to trauma or osteoarthritis. Joint tenderness and pain are present on palpation and passive horizontal adduction. Management. NSAIDs plus local steroid injection. Cleidocranial dysostenosis. It's an inherited autosomal dominant disorder. See, it's a structural disorder, so it's dominant condition. Part of all the clavicle, a part or all of the clavicle is missing, and ossification of the skull is delayed. So sutures remain open, associated with a short stature, and no treatment is there. 456 elbow problems. History. Pain and stiffness. Joint pain is diffuse pain well localized over the medial or lateral epicondyles, may be due to tendinitis. Deformity. Swelling. Is there swelling? Are there nodules? Is there a structural deformity? Loss of function. May be limitation of flexion, extension, pronation or supination. This can affect the function, causing difficulty in eating, can't get the hand to the mouth or with personal care. Neurology. Numbness and paresthesia distal to the elbow, particularly in the ulnar nerve distribution. Examination. Look, carrying angle 11 degrees for a male and 13 degrees for a female. Effusion may be visible either side of the olecranon. A discrete swelling over the olecranon could be RA nodule, gouty throphus, olecranon bursa, or other nodule. So if there's a nodule or discrete swelling at the olecranon, you should consider rheumatoid arthritis, gouty throphus, or olecranon bursa, or other nodules. Check for muscle wasting. Feel. Feel the tenderness, swelling or warmth. If indicated, test neurology and check pulses distal to the elbow. Move. Active and passive movements. Compare both the sides. Normal range is from 0 degrees to in full extension to 45 degrees in full extension. Zero degrees in full extension to 145 degrees in full flexion. Check the pronation and supination. Normal range is 75 and 80 degrees respectively. Tennis elbow and golfer's elbow. Epicondylitis. Common extensor tendon inflammation at the epicondyle. Tennis elbow. Common extensor tendon inflammation at the epicondyle causes a repeated strain. Tennis elbow. Tenderness over the lateral epicondyle and lateral elbow pain on restricted wrist extension. Golfer's elbow. Tenderness over the medial epicondyle and medial elbow pain on restricted wrist. Pronation. Management. Stop the trigger movements if possible. Often settles with time plus NSAIDs. Recovery is speeded by local steroid injection, but steroid injection may be associated with early recurrence. Physiotherapy may help, may an epicondylar clasp. Rarely referral for autologous blood injection or surgical release is indicated. Olecranon bursitis. Traumatic bursitis due to repeated pressure on the elbow. Olecranon bursitis. It's a traumatic bursitis due to repeated pressure on the elbow. Pain or swelling over the olecranon. Most settle with conservative treatment. Rest, eyes, activity protection below the elbow pads. Consider aspiration of the fluid from the bursa. Antibiotics if sepsis is suspected. Fluid may reaccumulate. If sepsis has been excluded, consider hydrocortisone injection. Refer if not settling after 2 months or complications. Ulnar neuritis. Narrowing of the ulnar groove from osteoarthritis, rheumatoid arthritis or post-fracture. Ulnar neuritis. Narrowing of the ulnar groove from OA, osteoarthritis, rheumatoid arthritis or post-fracture causes pressure over the ulnar nerve, ulnar neuropathy. Clumsiness with the hand is often a first symptom, and then weakness plus wasting of the hand muscles innervated by the ulnar nerve and decreased sensation in the little finger and medial half of the ring finger. Rule out metabolic and autoimmune causes of a mononeuritis and refer for consideration of surgical decompression plus nerve conduction studies if entrapment is likely. Dislocated elbow. Usually due to fall in an outstretched hand with flexed elbow, ulna is displaced backwards, elbow is swollen and held in fixed flexion, may have associated feature. Refer to the emergency department for reduction. So cases in which the elbow is dislocated is usually due to fall on the outstretched hand with a flexed elbow. Ulna is displaced backwards, elbow is swollen, hand held in fixed flexion, may have associated fracture, is referred to emergency for reduction. Pulled elbow is common in children less than 5 years. Peak age is 2 to 3 years. Traction injury to the elbow causes subluxation of the radial head. Often occurs when the child is pulled up suddenly by the hand. The child will not use the arm and generally holds the arm pronated in extension. No other clinical signs, males more than females, left arm more than the right arm. X-ray is unhelpful. Immediate recovery is seen after reduction. If unable to reduce or pain continues after reduction, refer to the emergency department for X-ray and further assessment. So these are the steps in pulled elbow reduction. Typical pose in elbow extension and forearm is pronated. Step 1. Place the thumb on the prominence of the radial head. Apply gentle longitudinal traction. 2. Supinate the forearm fully. 3. Flex the elbow. Technique for a pulled elbow. Wrist and hand problems. History. Wrist pain and stiffness. Pain is often well localized in the wrist. 5 conditions are associated with point tenderness in the wrist: decurrence disease, old scaphoid fracture, carpometacarpal osteoarthritis, clean box disease, avascular necrosis of the lunate, and tenosynovitis of the extensors. Wrist pain may also be associated with rheumatoid arthritis, osteoarthritis, and ganglia. Carpal tunnel syndrome is associated with pain in the hand. Deformity may be swelling of the tendon sheaths or wrist. Bone deformity is a late feature of arthritis or secondary to trauma. Function. Ask about weakness and numbness in the hand. Hand. Pain or stiffness. Pain from the hand is felt in the fingers or palm. A diffuse ache may be referred from the neck, shoulder, or mediastinum. Deformity may occur acutely, example due to tendon rupture, or slowly due to bone or joint pathology. The pattern of asymmetry of the joint involvement can be diagnostic. Function. Good hand function is essential for everyday tasks, turning keys, doing buttons, writing, asking about limitations. Ask about the limitations. Examination of the wrist and the hand. So for the wrist, look at the symmetry. Swelling or deformity, ulnar deviation, volar subluxation, rheumatoid nodules or ganglia at the wrist, muscle wasting in the forearm or hand. Feel the temperature, nature of any swelling, tenderness of the radiocarpal or midcarpal or distal radioulnar joint. Movement or measure. Range of movement. Normal range is of extension at the wrist is 75 degrees. Flexion is 75 degrees. Pronation is 75 degrees and from vertical, and supination is 80 degrees from the vertical. Is there any crepitation? Neurology. Check for ulnar or median nerve function. Hand. Look at the posture of the hand. The swellings, rheumatoid nodules, Herberdens and Bouchard's nodes, ganglions, trophi. So look for the posture of the hand and swellings. Could be rheumatoid nodules, Herberdens nodules, Bouchard's nodes, both seen in osteoarthritis, ganglions or trophi. Nail signs, pitting or psoriasis, scars, deformity, mallet finger, swan neck deformity, boutonniere's deformity, dupuytren's contracture, ulnar deviation. If there is any joint disease, note the distribution, whether it is symmetrical. Feel. Temperature, condition of the skin, dryness, sweating, nature of swellings, muscle bulk, example, small muscles of the hand, tenderness. Move or measure. Ask the patient to make a fist, spread his hands, her fingers out, and test each individual joint. Then test the opposite, pinch grip, key grip, palmar grasp of the ball, and practical task, example picking up a coin. Scaphoid and other hand fractures. Table 29.8. Ganglion. Smooth, firm, painless swelling, usually around the wrist. No treatment is needed unless causing local problems. May resolve spontaneously and can be drained by a large bore needle, excised, but often recurs. So we will stop here for today. We are at page number 459. We will continue from page number 459 tomorrow. Thank you. Have a good day.